Let's go to featured question number 3. What are your thoughts about treating cluster headaches? Well, let's review what cluster headaches are first, and we'll do a little bit of review of this. As we go through, we might get some ideas of what to do to treat them. It's not something that we see very commonly. I've only seen a few cases in my life, but the question came up, so I wanted to answer it because there's a kind of a hidden answer at the end here. Intense and severe unilateral pain, typically in the supraorbital, retroorbital, or temporal regions. That's what cluster headaches are. They can arise, it seems like they're arising from deep within the head. They can be bilateral or alternating, but typically they seem to be more on one side than the other. They're more common in men with a ratio of 2.5 to 3.5 men to 1 woman. Women tend to have more nausea and vomiting, often wrongly attributed to migraine. Cluster headaches are not migraine. Some people call them cluster migraine headaches, but they're actually a different kind of headache. They're sort of in the same category. But cluster headaches are not the same as migraine, need to be treated somewhat differently according to what your patient's needs are. They usually begin at ages 20 to 40, and the prevalence in the United States is 0.4%, so there are not that many around, as we say. Pain ramps up quite quickly and typically remains for 15 minutes to 3 hours, or 180 minutes if untreated. That'd be obviously 3 hours. It often occurs at the same time each day. I remember one guy told me I always have between 2 and 3 in the afternoon. It often awakens patients from sleep. Cluster headaches often accompanied by cranial autonomic symptoms such as ipsilateral lacrimation or conjunctival injection, blood vessel injection, nasal symptoms or oral fullness, periorbital swelling or ptosis or meiosis of the eye ipsilateral to the pain. These autonomic concomitants can be associated with the problem, and they tend to have greater or equal to 1 attack per day for 1 to 3 months. Cluster headache attacks cause unilateral pain in an orbital temporal distribution, excruciating, peaking within minutes, usually subsides spontaneously within 30 minutes to an hour, but could be disabling during the time that it's present. Patients are agitated, restlessly pacing the floor, can be so severe that it leads to bizarre behavior such as banging the head on the wall. Patients with episodic cluster headache have bouts of attacks. These bouts last 6 to 12 weeks, often more attacks in the spring or the autumn. So they go through periods of the year where they have these bouts for 6 or 12 weeks of getting these cluster headaches. They break between the bouts, can last more than 3 months. It can happen once every other day, up to 8 times a day. Patients with chronic cluster headaches have bouts with breaks of less than 3 months in between. They have chronic cluster headaches, so-called chronic cluster headaches, have bouts with breaks of less than 3 months in between attacks. Diagnosis is based on clinical history. There's no specific diagnostic biomarker. Atypical cluster headache patients suggested to perform an MRI or pituitary testing to rule out any pathology, maybe a pituitary adenoma, for example, or some other pathology within the brain when there are atypical patterns. Neuroimaging reveals posterior hypothalamic area firing during attacks, interestingly enough. Well, how do you get to that? Well, we'll kind of mention that in a moment. In a way, we're going to mention that. It's going to be what it's going to be. I'll tell you right now. I'll give you a clue. It's going to be fix what you find wrong. And the posterior hypothalamus area, as you know, is related to the antidiuretic hormone or vasopressin and oxytocin. But how do you get those? We fix what you find wrong. The pain matrix, the neurological pain matrix, is involved, and the central opioid system is involved. So cluster headache attacks can be triggered by alcohol, food containing nitrates or nitroglycerin. These are vasodilators. That's going to make us look at maybe nitric oxide, right? So maybe nitric oxide associated issues. And strong odors such as petroleum, paint, and nail varnish. So alcohol or food containing nitrates. This tells us pay special attention to QA steps 5, 6, and 7. Where you see in QA step 5 the bad fats, QA step 6 the food allergies, QA step 7 we have the bleach sniff test for inflammatory activity. We have the ammonia sniff test, which could relate to pneumonia issues, and we have the aldehyde sniff test, which relate to strong odors such as petroleum, paint, nail varnish, and so on. These things are already built into the QA protocol, as you see. Most commonly, cluster headaches prescribed therapies for acute treatment include sumatriptan, Imitrex, and oxygen therapy actually has been used, and zomatriptan, which is Zomig. These are some of the drugs, but oxygen seems to be a very popular medical treatment for this as well. Most common preventive therapies include Verapamil, which is a calcium channel blocker. Calan or Isoptin are the more common product names now, calcium channel blockers. topiramate or Topamax, anticonvulsant, lithium for bipolar disorder, or valproate, which is Depakote or Depakane. And as we know, valproic acid is oftentimes in patients who take valproic acid and having some benefit, but not total benefit, its activity can be potentiated by the amino acid taurine, either giving taurine or helping the body to make taurine through the methionine sulfur amino acid pathway. Excuse me, there are many reasons for various types of headaches. Cluster headaches tend to be on one side of the head, have autonomic concomitants, and are extremely painful. Excuse me a second. Maybe chemical triggers, including allergens, toxins, and detoxification problems, immune and inflammatory issues, etc., etc. Cluster headaches should be evaluated the same as any other headache or any other problem for that matter. That is, follow the QA protocol and fix what you find. That's the secret answer. That's the hidden answer at the end of this discussion. There's not a this for that for cluster headaches. You have to figure out what's wrong with them. You have to follow the QA protocol. And as we talked about through the course of this discussion, most of the things that are going to be involved that are typically thought of are going to be addressed as we go through the QA protocol. The answer to this question may seem like an evasion of the question, but in fact, the QA protocol was developed over decades of treating difficult patients, over decades of focusing on comprehensive correlated assessment of physiological processes rather than the symptoms of a name or named diseases. So you go through the protocol, now you can mix it up. You can say, I'm going to jump ahead because this patient says they're sensitive to aldehydes. I'm going to jump ahead to QA step 7 and check the aldehydes before you check maybe QA steps 5 and 6 because maybe their history doesn't indicate any bad fats or doesn't indicate any food allergens. But you want to go back and check those things eventually. You can, mess the protocol. You can mess around and take side trips on the protocol, but you want to always make sure you check all the steps along the way. And in a case like this, the patient says, oh, I paint my nails and I get the cluster headaches. Well, then you want to move that step up a little bit. But the fact is you're always going to start with IRT, and then you're going to go down through the QA protocol regardless what the problem is, even if it's something as rare as cluster headaches that we don't see that often. How do you figure it out? You go through the QA protocol because it covers all the things that could possibly go wrong with the patient. As we often say, if it walks into your office, QA addresses it.